My name is Domenica Cappellini. I'm a professor of internal medicine at the University of Milan, and I'm very pleased to be here today with my colleague, Dr. Kevin Kuo from the University of Toronto. Actually, we are both on the field of hemoglobinopathies, and we have some exciting data and new data during this ASH meeting. So, Kevin, do you want to say something on the novel treatment which have been presented here at the ASH?
Absolutely. As you know, those sessions are not here yet, but they will be here on Monday.
Yeah.
There is the gene therapy session, which will be here more about both CRISPR therapy, CRISPR-Cas9, as well as CRISPR-Cas12a, as well as the long-term study of Bluebird Bio's BB1111 or the Lovell cell therapy. Those are all very exciting. We see that there's really improvement in quality of life in the long-term treatment up to 6 years, as well as there's also transfusion independence in patients who receive the CRISPR-Cas9 therapy. And there's some preliminary exciting data as well from the CRISPR-Cas12a, which is from the Editas.
And for CRISPR-Cas9, the news which really is exciting was the approval by FDA 2 days ago for sickle cell disease, and most probably it will be also coming approved for thalassemia. Beside this, let's say, molecular approach, which is a cure of the disease, have you been excited by some results of the pharmacological treatment of ineffective erythropoiesis or red cell metabolism? Can you say something to that?
Yes, absolutely. And Nika, you and I well know that there are limitations with gene therapy, particularly with the use of myeloablation.
Yeah.
We can get to that later, but let's start with the pharmacologic therapy. There's Luspatercept. There is now long-term data on the improvement in quality outcome with the Beyond study. So in that, of the patients that were on Luspatercept, we see that there was a continual improvement, sustained improvement in the patient-reported outcomes.
And this is a drug already approved either by FDA and EMA, and the let's say approval was for treating anemia in transfusion-dependent or non-transfusion-dependent thalassemia. And nowadays, as you said, we have long-term data which not only present a sustained response, but also we start to see an improvement of quality of life.
Yes.
And what about PK activator? You are the leader of these studies.
Well, it's very exciting to say that we continue on both the ENERGIZE as well as the ENERGIZE study for mitapivat, and for the FT4202 etavopivat, the Gladius study is also ongoing. We currently do not have data results yet for those two, but I'm eagerly awaiting for future results next year.
And that's also, although the mechanism of action is different than Luspatercept, but definitely the result of the phase 2 were very exciting. So we have nowadays a new scenario of treatment of thalassemia as well as sickle cell disease, and in the coming years, for sure, we will have, let's say, several different approaches to be adapted to patients. So we are moving to precise medicine. And the challenge nowadays, from my point of view, is to be able to define a specific profile of patients, identifying some biomarkers which allow to identify those who are more susceptible to be treated in one way or the other. And this is very challenging, but definitely very exciting.
So Nika, as you know, many of our patients still suffer from many complications from thalassemia. Unfortunately, there is no good way of reversing that, even if, say, they do engage in gene therapy or some other disease-modifying agents. Do we have any news on how to manage that?
The survival curves now are completely changed compared to the past. We have thalassemia patients over 50, even over 60, and definitely we are starting to see complications or morbidities which were not common in the past. I look around, there are no many data presented at ASH, but a few things are underlying. One is, for example, the increased prevalence of arrhythmia in adult patients, which is not really related to the iron overload, because most of these patients are well chelated, but probably, considering that atrial fibrillation is common in a general population, but here is even more common compared by age, and it appears earlier. Why is this happening? It's just because the myocardial tissue is fibrotic. We don't know, but we have to look at that. Another morbidities, of course, which is now occurring, are tumors, cancer. That's true particularly for liver cancer, and that can be explained by iron overload, hepatitis C infection, but definitely is more prevalent in adult patients, and is also difficult to treat. And so we are trying to look now to all these clinical morbidities which were not used to see before. So I would like to say that we have to look further and write the history of the adult thalassemia patients in order to see how to treat them or how to prevent them.
But I think what you just said also highlights the fact that these patients, as they get older, will need some form of treatment.
Of course.
And gene therapy being so restrictive in terms of inclusion for age probably is not the right choice. So disease-modifying therapies, like Luspatercept, for example, or even other pyruvate kinase activators would probably be helpful.
I definitely think that we should look carefully at the different population, the different option, and as you said, it's not our duty, but the cost of gene therapy, genome editing will definitely limit the application. So selecting the proper patients has a cost benefit which has to be considered.
I think it goes beyond cost, right? Because it's about the resources. It's not just about the cost of the gene therapy. It's also the need for inpatient beds, nursing, the doctors, the phoresis, imaging.
So it's nice to have the possibility to use also maybe before gene therapy pharmacological approaches and see how they behave and how the results. So definitely the coming years will be for the young physician treating thalassemia a very fascinating and challenging time. And for the patient, of course, they are starting to see what they were looking for since many years.
Having choices empowers both the clinicians as well as the patients.
Definitely.
Yeah. Last but not least, I want to bring back the idea of precision therapy, because you talked about the precision medicine, and I saw something very fascinating today at some gene therapy session. We are currently challenged by the fact that we still need to do full myeloablation for gene therapy.
Yeah.
What I did see today, though, was very fascinating. There was an abstract, oral abstract, on the use of anti-CD117 ADC in monkeys to deplete the CD34 positive stem cells. I think that is one way of doing myeloablation without the toxicity of chemotherapy. And in that study, they showed that the rhesus monkeys were able to reproduce. There was another one where in using both a truncated EPO editing by truncating EPO receptor and also the addition of alpha globin, that they were able to rescue the stem cells of CD34, the CD34 positive stem cells of alpha thalassemia.
Fantastic.
So, as we all know, alpha thalassemia major is a huge area of unmet need. I mean, there's very few of them, but they're very hard to treat.
Those are very,
Yes, yeah.
So that will be a step forward, because the myeloablation with the busulfan is still a concern, because we know the impact of busulfan. And patients sometimes, although they are keen to have the treatment, when they realize the risk, they step down.
Exactly.
So having other possibility for doing that will be another step forward.